Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything else which crosses our mind for infectious disease, infection prevention, inflammation, etc. This is the week of June 5th, 2023, and at least so far as COVID-19 goes and SARS-CoV-2, it has pretty much been a backseat to other things in the world. To wit, our questions today actually have no COVID associations and some other interesting fun stuff. In terms of the state of the world for viruses out there, there's just a very few numbers of SARS-CoV-2 cases out there, and currently, at least in my institution, no pediatric patients who are hospitalized or even being seen in the emergency department. Of course, there are plenty of other respiratory viruses out there yet still. Adenovirus continues to make its presence quite well known, and certainly some still nasty croup with parainfluenzas, and we recently had a case of bacterial tracheitis superimposed on adenovirus and parainfluenza. So respiratory season is still out there. Yes, of course, it is also acute gastroenteritis season, especially as we hit the summer months. Norovirus, rotavirus have been out there significantly, and I expect we will start to see entrance of the bacterial enteritis now. So Salmonella, Shigella, Campylobacter, 'tis the season, folks. So it's out there, and I'm sure we'll be seeing a lot of that coming in through our sick visits and urgent cares and emergency departments. Today's questions, however, are very interesting. The first one has to do with patients with chronic mold exposures, and I imagine most of you in the listening audience have had at least one patient in your practice or your experience who sort of fits into what this questioner is asking about. And it's a long question. I'll just basically summarize it. The questioner has several patients who are being followed by naturopathic physicians, and this is true, there are plenty out there, for mold exposure and sensitivity, and they're being treated with interventions that I think probably foreign to many of us, such as activated charcoal, astragalus, a couple others. Sometimes these patients actually are sent to me for consideration of anti-fungal treatment, but they're being treated by the various products by naturopathic physicians, the varying degree of controls, and they're being followed by a variety of labs, many of which are cytokine-based, some of which are complements like C3A, C4A, and then TGF factor beta 1, TGF beta 1. So basically the question is, what is up with all of that? Is there any scientific validity to these? Why are we following cytokines? And why are we either starting or stopping treatment based on levels of these cytokines? As one looks at the literature, there is, as you might expect, some which is actually quite reasonable and evidence-based and scientifically makes sense, and some which is sort of pushing the limits of scientific validity, but discerning through the mix of those that there are some peer-reviewed publications which I think do have some validity, and in them they look at not just the mold exposure itself, but exposure to the mycotoxins, so toxins associated either with antigenic structures on the cell walls of the molds, or in some cases actual proteins secreted by the molds once they establish a chronic infection in our patient. And it is either the mycotoxins or these antigenic secretions which are triggering a chronic inflammatory reaction, ultimately creating something called CIRS, or chronic inflammatory response syndrome. And think of this as another in the category of diseases similar to post-acute COVID syndrome, so PAX or long COVID, chronic fatigue syndrome, and several others, in which the patient just isn't doing well. And it can be things such as malaise, decreased cognition, dizziness, decreased balance, certainly fatigue, decreased performance, etc. And I know in past years we have all been quick to sort of like, it's just in your head, suck it up, let's go. And I think as a counterpart to that, I need to offer that there are indeed very clear cases where patients, especially our high-performing, sort of the type A personality student athletes who are incredibly productive in their lives, are hit with something hard, and it's a huge change in their life experience. So yes, there absolutely could be a psychological component to this, including depression, anxiety, but also there is, I think, a medical component of this as well. And certainly a state of having chronically activated cytokines and chronically activated cell-mediated immunity. So T lymphocytes, B lymphocytes producing antibodies, and then downstream like cell effectors such as macrophages, monocytes, neutrophils. All these absolutely have great potential to create true clinical disease. So in that mix then I think comes chronic inflammatory response syndrome, triggered by a chronic inflammatory exposure to mycotoxins released by these molds, to which patients typically are exposed in an environmental source. So how do we look for that? How do we manage that? And this is where the testing for various cytokines and the TGF-beta1 has come. Specifically, TGF-beta1 seems to be one of the more specific and perhaps sensitive indicators of chronic mycotoxin-induced CRS. I think, and this is a return back to medical school 101, but basically TGF-beta1 is one of the central cytokine-based intracellular signals which can trigger cells into proliferation, differentiation, and also programmed cell death. So it is very much a central controller, and it is going to be upregulated in times of physiologic stress. I mean, it's the body's stress response to disease or unhealth, not being well. So that, along with some of the more classic pro-inflammatory cytokines, so thinking of your interleukins, thinking of your interferons, especially for viral infection, and indeed also looking at innate immune system components such as your complement, so C3 and C4, which are going to be central sort of points of convergence with your classic and alternate pathways. All these are going to be upregulated under the setting of a chronic inflammatory trigger. So it makes sense. It passes the sniff test, if you will. And so the valid science out there, I think, recognizes that fact. That's reasonable. However, what is, I think, still in the nebulous gray area is how predictive these levels are for either response to treatment and also what is the true efficacy of some of these various treatments. And nothing against our naturopathic colleagues in the community, but there are certainly some interventions they perform which are based very much on pseudoscience and poorly conducted studies or no studies at all. Perhaps the never pass a sniff test anecdotal experience, like worked for my last patient, let's try it for this one. So in somewhere in the middle of this are going to be those patients who do have both a clinical response and an improvement in the cytokine levels, including the TGF-beta1. And yay, great, wonderful, fantastic. Honestly, if the patient is feeling better, doing better, and has returned or is returning to life as the patient knew it, great. Who cares if it is perhaps a placebo effect or if there's true medical effect? The challenge, of course, is then looking for adverse effects of those interventions and also not losing sight of the fact that other actual medical diseases could also inform that patient's symptomatology. So I think that's sort of my 2 or perhaps 3 cents worth on trying to understand what we're asking about, what we're talking about. And the next part of the question is, what is our responsibility as practitioners in this situation? Should we get in the middle of this? And I think, quite honestly, keeping in mind that these are patients who are experiencing change in life, who are suffering, and by extension that the families, the caretakers are as well. We need to be very supportive of the process if we can help grow them back into health. But I think we also have a need as practicing clinicians to do due diligence in exploring other potential etiologies of the patient's symptom complex. So a reasonable evaluation for that patient presenting with chronic alteration of health, so chronic fatigue, chronic cognition changes, chronic myalgias, etc., is to do a reasonable evaluation for underlying malignancy. So yes, doing the screening CBC with a peripheral smear, considering a uric acid and a LDH to look for proliferative diseases such as leukemias and lymphomas, considering sending serologies for Epstein-Barr virus and cocci, and perhaps also considering long COVID, seeing if they've had COVID in the preceding 6 months or so. That's a reasonable approach. And also our markers for health, which may be a simple renal function, perhaps liver function, glucose control, and thyroid function. So all those, I think, are a reasonable, not too much, not too little approach just to ensure we're not missing major categories of clinical disease. And then if the patient is experiencing improvement on the interventions for their chronic mold exposure and their cytokines are improving, I think we can just simply provide support, guidance, and be there when the patient is ready for further interventions. Last part of the question, are certain people really more susceptible to this CIRS, the chronic inflammatory response syndrome from molds? And if so, what should we be looking for in this regard? It's a great question, and of course I would, the first knee-jerk answer is no, everyone is equally susceptible to molds and susceptibilities to mycotoxins, but I think that actually would be inaccurate. As is seen in other specific antibody or hyper autoimmune susceptibilities to other infectious triggers, so too should there be a population of patients who construct of circulating antibodies and antigenic recognition sites and toll-like receptors are primed to respond to specific antigens which might be associated with molds. So some patients get triggered by viruses, some patients get triggered by dust and allergens and pollens. There are going to be some specific patients who are triggered by chronic mold exposure and the mycotoxins. And that just makes complete reasonable sense. That is an understudied population of patients, to be completely honest about it. And I think that is certainly an opportunity for further well-controlled research and peer-reviewed publications to help us better understand that. What should we be looking for in this regard? I don't think there are going to be any predictive signs, symptoms, phenotypes, or anything like that. Certainly there's no genotypic testing that we can do, other than to recognize that taking a good, careful environmental exposure history for that new patient presenting with symptoms or for the long-term patient who develops new symptoms. And I've had patients referred to me in ID clinic who are very concerned about environmental exposures. They have potentially had mold testing performed in their place of living, and a word of caution for that, there are some that are very good and would be certified by the Better Business Bureau, and some that are very much hokey. So a word of caution to converse with our patients and their families about how to search for an environmental tester for mold presence. But for those patients who have, sort of the sick building syndromes, like he's fine when he's outside, but as soon as he gets inside, coughing and wheezing and cognition changes, etc., then I think it's reasonable to proceed down that pathway. So thank you, whoever sent that question in. This is quite a stimulating one, and I wish I had more hard cold evidence to offer in response to that, but it's not to deny the significance, the clinical significance of this area of medicine, but simply to say that there's more yet to be discovered, tested, and published in this area. Okay, next question asks, we are entering the summer months, and with primary amoebic meningoencephalitis cases on the rise, PAM, what measures should healthcare providers take to enhance early detection and timely treatment of the infection? So I expect if anybody is receiving either media reports or is on sort of a emerging infection listserv, that you've seen some reports coming from so far other parts of the country, but certainly we've had them here in Arizona, about amoebic meningoencephalitis, typically a source associated with freshwater exposure, swimming, splashing. It's usually in warm fresh water, such as lakes, which may not have very good flow, and to a lesser extent, some of the procedure-associated meningitis coming to us from Mexico, some of which are amoebic in nature. The principal amoeba of interest is Naegleria fowleri, but there are many others as well, many which are associated with either a one-time or a chronic exposure to warm water in which the amoeba develop. Great, that's what it is. The challenge, of course, is that the presentation of a amoebic meningoencephalitis, whether it's acute, primary, or even chronic, is very nonspecific and very indolent, and is quite similar to the onset of other forms of meningitis. So starting off with the 1 or 2 days of malaise, flu-like symptoms, developing that into headaches which have varying severity, some degree of meningismus, so nuchal rigidity, but even that is not strongly predictive, headaches progressing, sometimes vomiting, and then developing some focal neurologic signs. As we approach the summer, of course, the principal cause of that indolent nonspecific meningismus type presentation is going to be an aseptic meningitis typically caused by enterovirus. I mean, that's when it occurs. That's when we see enteroviral meningitis occurring. And the initial several days of presentation are going to be very much like that. So too with early onset for a bacterial meningitis. Typically, meningitis caused by Neisseria meningitidis or meningococcal meningitis is far more rapid and fulminant in its onset. I mean, we've certainly heard the horror stories of the high school student who went from well to dead in 36 hours, and that can be true. More typically, onset is 1 to 2 days, and progression to fulminant clinical disease another 1 to 2 days. That would be meningococcal meningitis. Pneumococcal meningitis and some of the others out there take a little bit longer, but we're talking days, not weeks, for sure. Those patients are going to present to either us in clinic or certainly to the emergency department, and they all deserve an appropriate evaluation for meningitis, e.g. Lumbar puncture, spinal fluid, and increasingly as the PCR-based detection methods are becoming more available, having some molecular diagnostic step to look for some of the typical causes of meningitis. Those molecular diagnostic steps, the PCR-based panels on spinal fluid, are not going to detect your amoeba. They're not designed to, because they have to decide how many targets to include and therefore how costly it is to the patient to perform that test. So you will be able to exclude viruses and bacteria and usually things like Cryptococcus, which usually is associated with those who are immunocompromised, immunosuppressed, but can occur in an immunocompetent individual. So I would suggest to us that if we have a patient with signs and symptoms of meningitis, so headache, confusion, vomiting, plus minus neck pain, and the spinal fluid initial indices are not strongly suggestive of a huge meningitis response, i.e. Cell count which is minimally elevated, protein glucose which are not significantly abnormal, and their molecular diagnostic steps are negative, those are the patients in whom we need to consider a primary amoebic meningoencephalitis or perhaps the chronic granulomatous encephalitis due to amoeba as well. Obviously, not everyone has access to the molecular diagnostic steps, and not all treatment centers or academic centers have that either. If they do, it's a delayed send out, it's an add-on, and you won't get your answer back for 3 or 4 days. Not very helpful. So the other major thing we need to be performing then in these patients as they present to healthcare, to our offices or urgent care, ED, hospitals, wherever you're working, is ask the exposure questions. So amoebic encephalitis cases, especially the ones in the summertime, are almost exclusively due to exposure to potentially dirty water. So has the patient been swimming in, splashing in, diving into especially freshwater lakes in the summer and in the shallows where the water is warm? Has the patient perhaps been performing nasal irrigation with products such as the neti pot using non-sterile water? And tap water counts, unfortunately, because especially tap water from wells can be contaminated with amoeba. You would like to think that treated municipal water, certainly such as we have in the cities Phoenix, Yuma, Tucson, etc., should not have amoeba, but even then, ew, gross, because there are other things in that treated municipal water, like Legionella, which you really don't want to be instilling into your sinuses. So there's, of course, a great opportunity for some anticipatory guidance and preventative maintenance. If one is going to do nasal irrigation, make sure you use sterile water and or a product bought off the shelf, such as the saline sprays or something like that. Exposure history. If patient has, we just had a family weekend trip to, Lake Powell, for example. Now, I'm not singling out Lake Powell. There's not been cases associated, but just as an example. And this patient was diving off the dock into the warmer, shallower parts of the lake. That would be considered a risk factor, and then we should consider primary meningoencephalitis. If you have that concern, and I think we need to have a very high index of suspicion and low threshold to have that concern, that patient requires emergent referral to the closest high-level care children's hospital, where they have the resources for ICU support, for rapid neuroimaging, potentially brain biopsy, which is going to help us confirm the diagnosis in some cases, and then to rapidly initiate the very experimental and difficult to achieve treatment, which is usually 4, sometimes 5 drugs, several which will need to be flown in by the CDC to treat that patient. The treatment outcomes, by the way, are abysmal. I personally have cared for 3 such patients, none of whom survived. So doesn't mean that we should stop trying. It certainly means that we should do everything we can to identify the patient earlier. But I will caution us that early diagnosis is rare in the setting of amoebic meningoencephalitis because we have to exclude the other stuff, and we don't always get that exposure history. So, sorry, that's kind of a downer of a response, a deadly, horrible disease, which does not have any striking features other than the exposure history to guide us. And all I can answer to the questioner is like, keep it in mind, think about it, ask for exposure, and have a very low threshold to refer for further testing if you have a suspicion of amoebic meningoencephalitis. Okay, next and last question. Can I provide more details about the current universal flu vaccine trial, which is being conducted in partnership between the NIH and Duke University in Durham, North Carolina? Yeah, so this is exciting. This is the second universal flu vaccine product to be tested. The first one was a polysaccharide based and had varying degrees of success, and that is entering into later phase trials right now. This current study, the one being both the vaccine developed at Duke and being tested through Duke as the primary center, is entering phase 1 trials. It is an mRNA vaccine, so a messenger RNA vaccine, which encodes a stable part of the protein of the hemagglutinin component of influenza, and it's usually influenza A with a certain extent influenza B. So what do I mean by stable? So I think we all have seen with the current flu vaccines that the components of the vaccines change sometimes year to year, typically based on the types of influenza out there circulating. And by types, I mean identified by their expression of differing hemagglutinin. So, for example, H3N2, that's the hemagglutinin 3 antigenic recognition, and neuraminidase 2, H3N2, or H1N1, which is currently circulating, is the hemagglutinin 1. So there is a component of the hemagglutinin, which is an antigenic protein expressed at the viral capsule surface to allow it to bind to its target respiratory epithelium. A component of that, e.g. the binding site, is going to change, it's going to mutate. But there's a much more stable component of that same product, which is the anchor. It anchors the antigen, the binding site, to the capsule, that by extension kind of the cell surface. It's not a cell, but the capsule of the virus. That component does not change even with the typical drifting and shifting mutations of influenzas A and B. So if one can create a stable and reliable antibody reaction against that component of the hemagglutinin, that should create a universal flu vaccine which will protect us no matter what the antigenic shifting and drifting is worldwide. That's the concept. It's a very cool concept. The challenge with the very first vaccine product was it was not as immunogenic as had been hoped for. However, yay for science and lessons learned from the COVID-19 pandemic. See, I worked it in there somehow. I had to get something in about COVID. So because of our understanding now of the power of mRNA vaccine technology, it is now possible to introduce that same antigenic stable hemagglutinin protein component, but by precipitating it by mRNA code, which is then ingested, transcribed into that actual specific code, and triggers, or should trigger, a very strong immunogenic response. So far that vaccine has been tested. It does what it is supposed to do. It is now entering phase 1 trials, which is basically a dose escalation. That's the phase 1 components of vaccine trials, is what is the ideal dose, micrograms or whatever you call it, of the vaccine to precipitate the best response in terms of kind of a return on investment situation without going too far. And along with that also will be a comparison of any immediate reports of adverse effects. So the study is recruiting 50 test subjects ages 18 to 49. So it's not going to be pediatric yet. That unfortunately always comes later. But, that's okay, because if we get a safe, effective vaccine, it's usually, with the mRNA products, a rapid step to test safety and get phase 3 trials in pediatrics. So we're starting with phase 1 in adults. So 50 patients getting there are 3 arms of the vaccine trial with 3 different doses of the vaccine, and they'll compare them to healthy controls getting a standard quadrivalent vaccine such as we have already for other flu vaccine protection. And there'll be an additional 10 patients that will be used to further test perhaps the ideal dose once it's discovered. So comparative efficacy, safety trial, looking for adverse effects, and testing for antibody creation, and then protection against flu coming up, this coming flu season. So super exciting. It is absolutely a huge step in the right direction. And in talk with partners in the commercial world, once one gets to the phase trials, the phase 1, 2, and 3 trials, one already has a vaccine with demonstrable efficacy. So we're to that stage. The next thing is just tweaking it, modifying to get to exactly the right amount and the right delivery system, if you will, like, is a single dose enough? Do we need a 2-dose, etc., and so forth? So the time to get a working product and to prove that it works is rapidly approaching. This is huge. I think we all agree that having universal vaccines, which don't have to be modified every season for changes in the antigenic structures, would be very beneficial, certainly in terms of getting the patients back into the practice setting to give them that annual vaccine. So work continues along those same lines. Here it's coming again for a universal SARS-CoV-2 vaccine. That work is in much earlier stages in terms of identifying a stable universal target. So that yet is not anywhere near phase trials, but the flu vaccine is. So that is just, I think, super exciting. So those are the questions for this week. Again, thank you so much for these really interesting ones. Keep them coming. And as always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at AzAAP.org. And in the meantime, as always, keep hanging in there, keep fighting the fight, keep looking for strange and unusual things about which to question this podcast, and keep taking care of yourselves, folks. Wellness is important so we can help others. Thank all of you once again for your service.